Dr. Swati Phuljhele. I'm an additional professor at Dr. Rajendra Prasad Center for Ophthalmic Sciences, and I'm the chief instructor for this case. Along with me, we have our eminent speakers, co-instructors, Professor Rohit Saxena, who is professor, needs no introduction as far as neuro-ophthalmology goes on. And I also have so in the previous session, you saw Dr. Jyoti Matalia speaking about idiopathic intracranial hypertension in children. And I would be talking about the same thing in adults. There is some overlap, but most of the time the adult idiopathic intracranial hypertension is different from what we see in pediatric age group. So IH is a condition that is characterized by elevated intracranial pressure. And due to increase in global prevalence of obesity, there is increase in incidence of IH as well. And it has been shown that the moderate weight gain of around 55 to 15% is associated with greater risk of IH and in obese patients as compared to non-obese patients. Apart from weight gain, there can be secondary causes of IH like hormonal disbalance, hypervitaminosis, PCODs. Yeah. The clinical features include headache is the most prominent symptoms, which may be diffused and may be so worse that it may wake the patient at night and becomes even more worse in the morning. It increases with head movement, coughing or straining and is associated with vomiting and nausea with or without photophobia. Diplopia may be another complaint because of the abducens nerve palsy. There may be presence of pulsatile tinnitus. What is much more prominent symptom of IH is vision loss. It's a prominent morbidity also. And it is usually reversible if treated timely. 40% of cases will show vision loss sooner or later at some point of time, and 10% of these patients may actually land up in bilateral blindness. So IH diagnosis still remains the clinical diagnosis of exclusion, but there are certain criteria into which the patient has to fit before we diagnose the IH. Essentially, these criteria include that all other neurological features should be not there in presence of papilloedema, and only neurological feature that may be present will be a bilateral sixth nerve palsy. MRI may show certain subtle signs, and it can be confirmed with the increased CSF pressure, which should be more than 250 mm of mercury to 250 centimeter of water of water to label it as increased intracranial pressure. The papilloedema IH can be diagnosed without papilloedema also if all these signs and symptoms are there in presence of sixth nerve palsy and certain MRI signs. So what are the MRI signs? Why is MRI mandatory? So MRI should be done to rule out intracranial space occupying lesion. That's the first and the foremost indication. Then there are subtle signs in form of distension of perioptic subarachnoid space, partially empty stela, flattening of posterior sclera, and tortuosity and elongation of orbital part of optic nerve. MRI should be done whenever indicated to rule out cortical venous thrombosis. You can also do visual field analysis, which will show enlargement of blind spot or generalized peripheral suppression in cases of IH. The role of OCT is increasing day by day in neuro-ophthalmological conditions, and I think Dr. Smita would be talking about it later in this session. But in IH, it has multiple roles. One, it is used to differentiate papilloedema from pseudo-papilloedema, particularly Drusen. You can see the configuration of retinal layers. You can measure the thickness of peripapillary RNFL and GCL layers. Then it also helps in seeing the effect of the treatment, whether the edema is coming down over the period of time or not. Also helps in determining the cause of loss of vision. Thinning of GCL is suggestive of optic atrophy. There may be macular changes which, in spite of best treatment, may not cause improvement of vision. There may be choroidal folds which may again cause poor vision. So this diagram or these figures are just to show that how at presentation there was marked RNFL edema, which over the time has come down with the treatment, and at 6 months became as good as normal. But what normal RNFL may give you a good, a relief, but it is not a good sign always. So many of these patients who have normal RNFL will show thinning of GCL IPL layers suggestive of optic atrophy, which is eventually setting in these cases. So just monitoring RNFL may not be enough in this patient. You may also have to monitor GCL to look into whether the optic atrophy is setting in or not. So it has been, in our study, we have seen that the baseline GCL IPL thickness has a good correlation with the final visual acuity, and thus it's a better monitor. How do you manage a case of IH? So there are two main targets whenever you are managing a case of IH. One is vision and another one is headache. So you have to deal, because these are the two most debilitating symptoms of IH. So first one is to removal of the cause, whatever the cause is, whether it's a hormonal imbalance or if there is an ICSOL or some secondary cause. So you have to deal with this cause. So you may need an endocrinology support, you may need a neurology support. Second most important intervention is weight loss, medical management, and then in the last, surgical management. So weight loss, as I was emphasizing earlier also, so weight loss, if is done with the range of 6 to 15%, may lead to early resolution of papilloedema as compared to patients who do not have weight counseling and weight loss. So the impact of weight loss we have seen in our study was that the change in weight loss was very well correlated with the change in the grade of papilloedema, with the change in visual acuity, improvement in visual acuity, and improvement in mean deviation on the visual field. Coming to the medical management, so one is acetazolamide, and it's a very commonly used drug. Everybody uses it. And the international idiopathic treatment trial now has given us an evidence that acetazolamide, if given in proper doses, can lead to significant improvement in papilloedema and visual acuity. Then the other commonly used drug nowadays is topiramate, which is basically a carbonic anhydrase inhibitor and also helps in suppressing appetite, thus indirectly helping in weight loss. It also causes headache management, and it's given in doses of 25 to 50 milligram BD. Then you have surgical management, which is done only in refractive cases where the patient is not responding to maximal medical therapy. Surgical management can be done in form of either CSF diversion, optic nerve sheet decompression, or venous sinus stenting. As an ophthalmologist, our most common modality, most common surgical management is ONSF sheet decompression. And this is the video showing the same. So just like with any squint surgery, a limbal conjunctival incision is made, MR is hooked, MR is secured, isolated. Box sutures are passed through sclera to retract the globe. Then it's important to identify the optic nerve, which can be identified by the presence of vessels which are there. And once you have identified an optic nerve, a nick is given, and you can see the gush of fluid coming out of the nerve sheath. So it's just not enough to give the nick. You have to cut a window also there and see that it's good enough to be maintained. You close it as like with any other squint surgery. And to conclude, as I said, that clinical features and papilloedema are the diagnostic sign for IIH. MRI and MRV are needed to rule out ICSOL CVT. LP should be done to confirm the diagnosis, and it's important to rule out the secondary causes. The management includes management of the vision and management of the headache. So maximum medical management should be tried before one can do a surgical intervention. Thank you. May I now invite Dr. Rebecca, who is an assistant professor with us at Dr. Rajendra Prasad Center, to present her talk on neuroimaging.
So, very good morning, everyone. So coming to the discussion, bringing the discussion to neuroimaging in neuro-ophthalmology. So you see that neuroimaging actually has undergone quite a lot of change, and it has, dramatically advanced in the past few decades. Slideshow. Yeah. So dramatically advanced in the past few decades. And, there are a lot of techniques which have come up. So why should we know about these techniques? Because technically it's a job of a radiologist. But what happens is that if you're aware of these techniques, you can guide the radiologist as to what kind of imaging protocol he can use in your patient, and also interpretation becomes quite easy. So the questions are what to order and when to order. So just before we go on to the topic, remember that these imaging scans are provided in 3 sections. One is the axial, when we are looking from above; coronal, you're looking from front; and sagittal, where you're looking from the side. Now, CT scan, MRI. Now, CT scan uses the ionizing radiation to evaluate the tissue density. Now, this radio density, just to simplify things, remember that bone has the highest radio density. It appears white on CT. Air has the lowest one, so it appears black, and rest of the soft tissue that you see has some shades of gray in between. So what are the specific indications for CT where, CT is preferred over MRI? It's the bony lesions, when you want to rule out some sinus lesions, traumatic cases, hemorrhages, when the MRI is contraindicated, like metallic implants and claustrophobia. So look at these pictures. A case of trauma comes to you, orbital trauma, head trauma. So the investigation of choice is a non-contrast CT of the head and orbits. So you can, very well see these fractures involving the optic canal, and that can explain your traumatic optic neuropathy. Then multiple orbital wall fractures. You can see the prolapse of the soft tissue into the maxillary sinus in case of a floor fracture, and that might explain why there's a restriction. The patient is having some restriction or limitation of movement in upgaze. And also sometimes you might get an idea about the soft tissue. So here you see an extensive medial wall fracture and a little optic nerve avulsion. Okay? So, and then you have newer techniques like volume rendering techniques. Now this gives a beautiful 3D reconstruction of the bony, visual illustration of all these bony structures. So you see these fracture lines running around. So it gives you an idea about the surgical planning and management. In our orbital pathologies, well, we have a patient who presents with a proptosis in the left eye. You do a simple CT and the diagnosis is glaring at you. So you see the muscles are so hypertrophied, it's thick, so it's a case of a thyroid eye disease. Another case, she was a 2-year-old female who had a bilateral disc pallor, severe disc pallor. We got an MRI done. MRI just showed thinning of the nerves, but we could not find what the cause was. So then a CT was done. So CT indicated these hypertrophic, sclerotic bones. So this was causing the thinning of the optic canals, and this was a case of osteopetrosis. Then you can have intracranial pathologies, gross pathologies you can rule out, on CT. So it's preferable to use a contrast-enhanced CT in such cases. So there can be an occipital infarct. Now here in the second image, you see a suprasellar mass lesion. Now the third image is a little interesting. We do not know what to see because we are not radiologists. But when we provided the clinical history to the patient, that the patient had a right-sided vision loss and some problem with the, diplopia and all. So now what you see over here, the cavernous sinus, this side is homogeneous, but here you see some filling defects. So this was a subtle sign of cavernous sinus thrombosis. So that's why it's important to provide clinical information to the radiologist. Now coming to MRI, the preferred modality, it is the best, the modality for soft tissue resolution, and also does not provide a radiation exposure. So important, the 2 common sequences that you use is a T1. T1, to simplify things, the fat is bright, water is dark. So it gives you the anatomical details very nicely, it shows. And T2, it identifies the pathology, especially edema. Why? Because the water is bright in this. And contrast enhanced MRI, you use IV gadolinium. So whenever there's a breakdown of a blood-brain barrier, like in case of tumors, you see a post-contrast enhancement. Okay? Then, now these are some newer sequences which are of relevance to us as neuro-ophthalmologists. Now what is a flare? Flare means fluid attenuation. So as I told you, water is bright in T2. So what does flare do? Flare actually suppresses the signal from the normal water, that is CSF. So this is a flare, flare suppressed image. So CSF is bright here, but here it has been suppressed. So what's the advantage? Is that the demyelinating lesions, like in case of MS, NMOSD, it becomes it's highlighted. So that's the relevance of doing a flare. Then is the diffusion weighted imaging. Well, it assesses the restriction of water diffusion. So its prime indication is in early cases of ischemia, where you're suspecting an infarct. And the advantage is that even though the conventional MRI early in the phase of infarct may not show the change, it will be evident in a diffusion weighted imaging. So that's an advantage. Then comes the fat suppressed. Now, fat suppression, in T1 the fat is bright. No, but when you have to look at the optic nerve pathology, you should get a fat suppression done. So you see bright fat in the orbits, you cannot visualize the optic nerves. But once you have suppressed these the fat, you can very nicely now look for the optic nerve and associated pathologies. So that's the advantage of fat suppression. Then comes your 3D Fiesta and Ciscan. Well, this is a highly T2 weighted image and it gives a high resolution image. So for finer structures, you can do that, like for imaging the cranial nerves or sometimes even cysts. Then MR spectroscopy. While MRI is giving you the anatomical details, the MR spectroscopy gives you the chemical composition of the brain structures. So you can differentiate between various types of, the differentials. Like in this case, the patient has a ring-like lesion, basal exudates. Now, tuberculoma is confirmed because it shows a high lipid lactate peak and a low N-acetyl aspartate peak. Similarly, you have different biochemical, the various chemical, based on a chemical composition, you can also differentiate between glioma and a meningioma. So that's your MR spectroscopy. Now coming to each of these indications in neuro-ophthalmology. So first is a case of optic neuritis. Now if the patient has a very typical feature of optic neuritis, you can go ahead with a contrast enhanced MRI of the brain, flare images, and orbits, fat suppressed images. Then what do you see on the post-contrast enhancement of the optic nerve that confirms the optic neuritis? And on T2, you see these hyperintensities. So this is your demyelinating lesions. So this imaging not only helps you to confirm the diagnosis, but also helps you prognosticate the case. Because according to ONTT, if you have the baseline MRI shows these lesions, then there is almost 70% risk of progressing to MS. Now, if it's a case of atypical optic neuritis, then you should also add a MRI spine to your investigation, because you should rule out a transverse myelitis in such cases, okay? Now coming to optic neuropathies, whether bilateral, unilateral imaging is needed, especially in bilateral cases. A patient comes to you with such a picture, bilateral disc pallor, and again, you see this, basal exudates, ring enhancing lesions. So that shows, so a bilateral disc pallor indicates that the pathology is somewhere in the chiasma, or maybe in the tracts that's causing a descending optic atrophy. So it is probably related to this, like in this case, it's because of the tuberculoma, or it could be a bilateral optic nerve involvement, like in this case, it was a large sphenoid-side mucocele that was compressing the optic nerves. Unilateral pathologies, well, unilateral optic neuropathy, if it is a slowly progressive, then you have to rule out compressive lesions, okay? In such cases, you might also sometimes see the orbital signs like proptosis, dystopia, so that will help you localize where the pathology could be. Hemianopias, yes. So visual field effects respecting the vertical meridian, it's a very important indication for neuroimaging. So this kind of a field effect, you know where the lesion is. It's somewhere in the chiasma. So guide this and tell this to the radiologist so that he can screen that particular area and the radiologist provides you with the answer, okay? Then if it's a homonymous hemianopia, then where is the lesion? It has to be retrochiasmatic lesion. So in retrochiasmatic, it could be tracts and radiations or in the visual cortex. But if you see something like this, a macula sparing homonymous hemianopia, it has to be in the opposite occipital cortex. So then we have a case, 42-year-old male, was a known case of Takayasu arteritis. He presented with headache and bilateral sudden decrease in vision. The pupils and fundus were normal in this case. So neuroimaging is indicated. So we get a neuroimaging done, and what you see that the diffusion weighted imaging shows this extensive bilateral occipital infarcts. So what could be the cause in a young patient? So this MR angiography was done. So whenever you are suspecting some vascular lesions, you should get angiograms or venograms. So in this, angiography was done. So you find this extensive, here on the right side, you can see this intact channel of vessels, but here it's all gone. So carotid arteries, internal carotid vertebral artery was all thrombosed. So that led to an extensive infarct. In cranial nerve palsies, we have this elderly patient with a 6th nerve palsy. It could be a case of ischemia, but we got a screening MRI done and we found it was an internal carotid artery aneurysm. Then another case, but here with the sixth nerve palsy, you also see a lid edema and this conjunctival congestion. So this tells you something is in the orbit, probably in the orbit or nearby. So what we did was, and we found that there's a LR cyst. So it's a case of LR cysticercus. Now this is another interesting case. The patient was referred to us as a case of squint. This is a pediatric patient referred as a case of squint. On examination, we found that the child had dorsal midbrain syndrome because there was convergence retraction nystagmus and there was a upgaze limitation. So we got an MRI done and MRI showed a panhydrocephalus. But what's the cause? We don't know. Then in discussion with the radiologist, he suggested get a Ciscan done. And then we see this beautiful cyst lying in the ventricle. So that's the fourth ventricle. And this was actually a mobile cyst because it migrated from third to fourth ventricle, and so it was a live intraventricular cysticercosis. And accordingly, the patient was managed by the neurosurgery people. This is another case. Congenital palsies usually do not need imaging, but what prompted her imaging in this case was that she has a right partial third nerve palsy. There was an extensive facial hypoplasia and also complaints of intermittent headaches and occipital headaches. So we just thought of to get an MRI done, and it showed that there is an enlargement of the posterior communicating artery, and you see also the hypoplasia of the right-sided midbrain, the affected side of the midbrain. Then again, the radiologist suggested get a Ciscan done, and we could not visualize the third nerve on this side. So then a digital subtraction angiography revealed that there was a bilateral segmental ICA agenesis that probably led to the hypoplasia of the midbrain and brainstem on the affected side. So these are the ideal indications for neuroimaging, but especially if you have a pupil involving third nerve palsy, please get a contrast-enhanced MRI with a MRA to rule out aneurysms. You can also go for a CT with the CTA, and orbital pathologies you can rule out. Papilloedema, ma'am has already shown you. So get a MRV along with the brain and orbits, because it could be space-occupying lesion or thrombosis, or if nothing is there, then probably an IIH. So just to summarize, remember that the key to diagnosis still is your clinical examination and communication with the radiologist. Do communicate to the radiologist what you are suspecting, what are the DDs, what is the suspected site of the lesion, and if needed, even if the MRI comes back to you as normal, if you're still suspecting something, go back and discuss with the radiologist, because sometimes some subtle abnormalities can come up. Thank you.
Thank you, Dr. Rebecca. Now we have Professor Rohit Saxena with us, and he will be talking about optic neuritis.
Good afternoon, everybody. Good morning, actually. Still morning, and I'm sorry I was in another session, so I couldn't be here on time. So nice to see a filled hall for neuro-ophthalmology. This just goes on to show that how popular neuro-ophthalmology is becoming, and I'm glad to share that FICO has also started in neuro-ophthalmology. So eventually, if you're looking for some form of certification, okay. If you're looking for some form of certification for neuro-ophthalmology, the FICO neuro-ophthalmology is now available. So kind of keeping it separate, because we knew that neuroretinitis is not seen in cases of demyelinating optic neuritis or demyelinating involvement. So that is why it was kind of kept separate, and more likely either it was idiopathic, probably because we didn't know what is the possible etiology, and the other infections. Classically, again, conventionally, we were dividing optic neuritis into typical and atypical. And this consideration or this thought was based on the landmark ONTT trials that were done. So the way they described what optic neuritis at that time, the understanding was that it was uniocular, it was predominantly affecting females in the young, middle 20 to 50 year age group, mildly painful loss of vision over hours to days. The loss of vision could be subtle. Could patients come with 6/6 vision with just a little field effect or a quality deterioration like color desaturation, to complete. Virtually no PL has also been reported, although again, less likely to be demyelinating. Vision loss peaks by 2 weeks, 2 to 3 weeks, and then it levels off, and thereafter it starts improving. In unilateral cases, which is the typical presentation, there would of course be a relative afferent pupillary defect. You do not see a pupillary RAPD in a unilateral subnormal vision presentation. Do not think of optic neuritis. And as I said, the fundus could be anything from normal to papillitis. Various causes have been ascribed. Like I said, the most common at that time was multiple sclerosis, and now we've been talking about NMO. And of course, infections could present with a presentation similar to typical optic neuritis, and occasionally, especially in children, post-vaccination. Most of the causes are idiopathic in nature. And optic neuritis with MS, and at that time when the ONTT trials were going on, MS was the single most worry that people used to have. So it was seen that it would be present. Optic neuritis as a part of MS was present in 50% of the patients, and the presenting feature as optic neuritis for patients who eventually went on to develop multiple sclerosis was almost 20%. And recurrences, of course, were seen in the same in the fellow eye. Now, what now our understanding of atypical optic neuritis is? So atypical optic neuritis is, in a way saying anything that is not typical. So you would have a sudden loss of vision, immediate or hours. So immediate, think ischemia. A few hours, probably inflammation, especially around the nerve. It's usually over a day or two, the patient will definitely tell you the vision loss in typical optic neuritis. It may be painless or very severe. Both are not typical features. Older patients, bilateral involvement, severe disc edemas, a lot of hemorrhages, cotton wool spots. Vision loss progression or no improvement from up to 2 to 3 weeks. Think atypical. Recurrent episodes of optic neuritis, and like I said, no RAPD in a unilateral vision loss. Now, our understanding of the reason why we are classifying it as typical and atypical is just to give us a starting point to understand etiology. Typical optic neuritis presentation is more likely to be demyelinating in origin. Atypical optic neuritis is most likely not demyelinating in origin. It does not mean that demyelinating optic neuritis cannot present atypically. In children, we do see it appearing bilaterally, and anything can happen. But likelihood, so it's giving us a starting point of what we think the cause may be. So typical idiopathic, MS-associated, isolated, CIN. In atypical optic neuritis, you have a whole lot of possibilities, so our workup for atypical starts becoming more extensive. The diagnosis of optic neuritis essentially remains clinical, is based on the visual loss, the fundus presentation, the presence of RAPD, and of course the other visual functions, the visual evoked potential, and now we are using OC2 to a certain extent to help us, of course not in the diagnosis, but essentially to follow up the patient and help us to classify and understand the possible etiology. Again, no real investigation per se is required from a diagnostic standpoint. We still remain clinical in our appearance and our understanding, but baseline investigations like chest X-ray and electrolytes in an Indian setting would be essential, especially as you're planning to give IV steroids. The risk of a tuberculosis flaring up or, of course, electrolyte imbalances would be there. In atypical, of course, again, the key thing is to rule out infective, inflammatory, compressive causes. MRI, the next step, has now become the most important diagnostic investigation that we are going to order. It was important even in the times of ONTT, but now with our better and better understanding of the MRI features of the various subtypes of optic neuritis, MRI has now become a key. I would say, if possible, do an MRI brain and orbits with contrast in all patients you are suspecting to have optic neuritis. It is the amount of information when we add it to the clinical presentation is phenomenal. We are actually started deciding which way the patient is going to move. But of course, it becomes mandatory in recurrent optic neuritis, patients keen to know about long-term prognosis, patients with history or evidence of other neurological involvement, atypical cases, and in acute optic neuritis in children. So if you suspect, so these are various protocols, but the moment you're presented or suspected with optic neuritis, your protocol becomes T2 weighted with flare with gadolinium contrast. So MRI brain and orbits with this definition, or I mean, most radiologists would understand an MS protocol. It's as simple as that, an MS protocol. A spine becomes important if the patient has symptoms related to spine. Of course, again, if you talk to a neurologist, he'll say spine must first go. But as ophthalmologists, we're always thinking of cutting corners as far as funds and patients' expenses are concerned. So I would say theoretically, yes, it's important. But if you are suspecting NMO, or if you have a patient with history of spinal problems, any neurological weakness, tingling of the lower limbs or anything, then yes, it becomes essential. Like I said, MRI for optic neuritis, of course, ONTT told us it is the strongest predictor for a likelihood of developing multiple sclerosis in the long term. And there are classical features that have been described for periventricular plaques, of course, the optic nerve enhancement. So these are very clear features that help us whether it's optic neuritis or MS related or not. Treatment, we know that methylprednisolone 1 gram for 3 days has now become the sheet anchor of treatment. 3 to 5 days, we've moved on. If you're suspecting that there may be a likelihood of NMO, we even give it to 5 days. Alternatively, dexamethasone we were using, but now again, because our worry of NMO and our fear of NMO, we have, and of course now the easy availability of methylprednisolone and not so much cost, we have moved on to actually sticking with methylprednisolone. Now, just a word about long-term problems or how we can defer multiple sclerosis. Once you're sure it's a demyelinating optic neuritis, we have a whole lot of disease-modifying agents that have known to reduce the relapse rate of optic neuritis, of any neuritis or neurological symptom in the long run. So, of course, as ophthalmologists, we do not prescribe these disease-modifying agents, but you need to work with your neurologist to consider and plan for long-term prevention of the patient developing multiple sclerosis. In India, again, this is just a background history. In India, in the first decade of this century, we constantly were concerned, and entire Asia was concerned, that somehow our patients are not kind of conforming to the typical view which ONTT has described for optic neuritis, and our patients were having a higher incidence of papillitis, bilaterality was more common, painless vision loss was there. Final visual outcomes were nowhere near what ONTT was talking about. They were saying 90% plus having 6/9 or better, and we were just not having that experience. We didn't find so many brain lesions, and somehow MS was not such a common feature in our patients. So, of course, we had this clinical profile again. When we compared, we found that Asia per se was definitely leaning away from the classical picture presented by ONTT. And over time, the last 2 decades, our understanding we have understood that things have that we face, or we have a more likelihood of an NMO related optic neuritis, which is in presentation and long-term prognosis different from multiple sclerosis. In fact, a couple of studies have shown in India that 10 to 20% of patients who present with a feature of multiple sclerosis actually are NMO positive. So NMO positive antibodies are present in at least 10% of them. So that's how our understanding and our management and intervention of optic neuritis in India and Asia has changed. There's higher visual impairment, poor recovery, and more severe and significant involvement of the spinal cord. So NMO, the importance is bilaterality, recurrent, profound loss, poor recovery. So these are all changes. Lekhi Pandit, an outstanding piece of work she has been doing on NMO. And it's important, again, like I said, the importance of MRI. You're able to pick up a different involvement of the brain in NMO as compared to multiple sclerosis. So you have a totally different set of lesions more often than not that are seen in the hypothalamus, the brainstem, and these are areas that are, if you have involvement of these areas on the MRI, you start thinking of NMO, and it's very important to early think of this because your management starts becoming different. Your initial management remains the same. You give high dose methylprednisolone like you would give for optic neuritis, MS related, but we tend to go on for at least 5 days. If the patient does not improve, you may actually have to discuss with the neurologist and talk about plasma exchange. So it becomes an important intervention. We've seen that patients who are, this intervention has shown to have better visual outcomes over the long term. And of course, you remember that for prevention of further attacks in NMO, immunosuppressive therapy has to be used. Disease-modifying agents that are beneficial for preventing development of multiple sclerosis in the long term are actually contraindicated and have resulted in poor long-term prognosis in patients in NMO. So the other antibodies that have recently come out and our understanding is gradually developing is anti-MOG. So MOG is another variant of optic neuritis that we are seeing. You have a presentation which may be similar to optic neuritis, but recurrences are more. And although, again, initial management is the same, our understanding of long-term outcomes, which are better in MOG-associated optic neuritis, are still developing. So these are differences that you see on an MRI, and this is how you understand, or your first impression. So if you do an MRI, you find you're able to kind of understand which of this you are landing into. The moment you think that it is not this, if it's clearly this, sure, go ahead and treat as an MS patient. If it is not this, there are no MRI changes, or there are anything suggestive of this, go ahead and get an NMO MOG test, because earlier you get to know, the better it is for the long term. This is just a pictorial description of the MRI changes that you actually get to see in the various types of optic neuritis. So just to sum up, optic neuritis typical features: IV steroids improve, follow-up. No significant improvements or steroid dependence, and you're seeing that it improves at the moment you stop steroids, the vision comes down. Revisit history, clinical examination, start thinking of NMO, MOG, get their sample blood testing, serology markers done, CSF analysis. Or if the patient presents with atypical features, you come straight here, start thinking of other causes of optic neuritis, and of course the management becomes tailored depending on what you are thinking. As I've discussed, there are a lot of options for each, but as an ophthalmologist, our key understanding is what are we thinking in the first go, because it's the initial intervention that is really affecting long-term prognosis. So optic neuritis can be a part of MS. Atypical features, think NMO, MOG, baseline MRI essential, steroid speed recovery, but you may need to do a long-term understanding of the disease profile. Thank you very much. I just invite you to the INOS that will be held in New Delhi on 26-27 November. So hopefully with this attention, we may have a better and a very interesting neuro-ophthalmology conference. Thank you very much.
Thank you, sir, for that wonderful talk on optic neuritis. Ischemic optic neuropathies were supposed to be covered by Dr. Digvijay, but unfortunately couldn't join us with us today. And that talk will be presented later at the end of the session. And now I invite Dr. Asmita to present her talk about the role of OCT in neuro-ophthalmology.
Good morning, everyone. I'll be discussing optical coherence tomography. Is it mandatory for neuro-ophthalmic disorders? So OCT was basically designed to be used in retinal diseases and glaucoma, but it is now becoming a fast, non-invasive method to see the anterior part of the visual pathway as well. Mainly, we are using RNFL OCT as well as macular ganglion cell complex analysis. In the RNFL OCT, what we do is we make a circle centered on the optic nerve head with a diameter of 3.4 millimeters. The normal RNFL thickness in this area is seen to be about 105 micron, with an estimated physiological occurring at about 0.01% per year from the age 18 onwards. This is an example of the RNFL OCT printout. As we can see in the center, we can see the quantitative ONH parameters, and in the color coding area, we can see that the green is depicting average measurements within normal limits, yellow is depicting that it is within a borderline range, and red is depicting that it has gone outside the normal limit. In the ganglion cell IPL thickness measurement, which we do in cases especially where we see then RNFL edema is present. So that can cause a mask of the thickening or thickening changes occurring in the RNFL. So in these cases, GC IPL thickness is a more reliable indicator of early damage. This is a printout of a GC IPL thickness analysis. In our Spectralis OCT image available at our center, we can even do a volume analysis in addition to the thickness analysis. So what are the uses of OCT in the areas in neuro-ophthalmology at present? First is in multiple sclerosis patients. In addition, we can use it to differentiate optic disc Drusen from Papilloedema. We can use it in patients of ischemic optic neuropathies. We can use it in patients of IAH or Papilloedema. And additional uses include compressive optic neuropathies, LHON, or toxic optic neuritis. So coming to multiple sclerosis, as we see that optic neuritis is frequently the first manifestation in about 20% of the patients of multiple sclerosis, and even after the vision has recovered, they report that they are having subjective visual dysfunction. So documenting of this subjective visual dysfunction sometimes becomes a little difficult. We do have low contrast visual acuity and visual field testing for this particular parameter of analysis, but we can also use OCT for the same. Another thing that we notice is that some patients do not recover complete visual acuity after recovery from optic neuritis. So a study was done which showed that patients who had RNFL values less than 75 microns after 3 to 6 months of the optic neuritis episode did not recover visual function. This particular duration was taken was because in the first 2 to 3 months, there might be some edema changes at the optic nerve head, and after that settles down at 3 to 6 months is when we can get a good idea whether or not the patient will return to their full visual function. And if the thickness was found to be less than 75 micron, these patients were found to not return to their previous visual acuity. Another thing that patients have been noted to have is that a subclinical RNFL loss is occurring amongst patients, which is occurring in spite of having no episode of optic neuritis or episode of visual dysfunction. So here comes our first utility of optic neuritis patients, that this particular 3 to 6 months duration can be a window to detect RNFL thinning, and we can predict whether visual recovery will occur in these patients. Another thing can be that if you are using regenerative strategies, they are best initiated within this 6 months of the acute optic neuritis event, and they would be the most beneficial at this point of time. So another thing that we can do in optic neuritis patients is that the macular volume is decreased in relation to the temporal RNFL quadrant thinning, and that can also be analyzed in these patients. Balzer et al. Have found that for every 1 line change in low contrast letter acuity square, an average RNFL thickness difference of 4 micron was noted. Here comes another indication of using OCT, a non-invasive approach to monitor the efficacy of any new therapy promoting neuroprotective effects on the ganglion cell neurons. A decrease in average RNFL has been shown in patients with Alzheimer's disease, Parkinson's disease, but its correlation with disease duration or disability is still being identified. Another utility again comes that we can measure the RNFL thickness and the macular volume as a surrogate marker for axonal loss which is occurring in the brain. These are some of the studies published at our center. Saxena et al. Has found that RNFL thickness is reduced in optic neuritis and multiple sclerosis in correlation with the magnitude of visual impairment, especially the visual field. The maximum thinning which was found in our study to be in the temporal quadrant, which was indicative of affliction for the papillomacular bundle. This was a 37-year-old male patient with a history of relapsing remitting multiple sclerosis, but interestingly, the patient had never had any history of optic neuritis, and he came to us with a 6S vision just for a regular checkup. When an RNFL OCT was done for this patient, we could see that there was a significant RNFL thinning in the temporal quadrant along with the changes in the GCL-IPL thickness. This was showing that there is an insidious atrophy of retinal nerve fiber layers occurring in this patient. Then another indication comes in patients of optic disc drusen. It is very essential to differentiate between optic disc edema and optic disc drusen because optic nerve head drusen usually has a benign course and there would be rarely any visual impairment or visual field defects. When we see a yellow glowing hyaline body over the optic nerve head, it is a very easy diagnosis. However, for buried drusens, B-scan ultrasonography and CT scan have been the gold standard so far. But upcoming could be OCT. So how will you differentiate optic nerve head drusen and true disc edema? An interesting feature has been seen that in a patient of optic nerve head drusen, the nasal temporal thickening was different. The nasal area was shown to have thinning, but the temporal area was shown to have thickening. This was because the drusen was usually present on the nasal part of the optic nerve head, and with progressive compression over the nasal fibers, it led to a thinning of the nasal optic nerve head. This was different from true disc edema, in which the RNFL thickness was increased in almost all the sections. So another thing that we have seen is that in optic nerve head drusens, there is a lumpy, bumpy internal optic nerve contour, which I will be showing subsequently, as compared to a recumbent lazy V pattern, which is seen in patients of optic disc edema. Sometimes we may also see a hyperreflective mass under the peripapillary retina, especially in the nasal area on the OCT. This is one of the findings which has been described by Lee et al. In the patients of optic nerve head drusen, they have described a boot-shaped appearance because the outer plexiform layer and the RP epithelium diverge as they approach the optic nerve head, and a boot-shaped area is observed adjacent to the optic nerve head drusen. This is the area which they have described, that there is a boot-shaped appearance just next to the optic nerve head drusen. This is a finding shown by Bassi et al., in which they showed that there is a triangular subretinal hyperreflective space in papilloedema, and sometimes you can see a buried optic nerve head drusen in patients of pseudopapilloedema on the OCT. This is the lumpy bumpy appearance I was talking about. The lumpy bumpy internal contour of the optic nerve head in optic nerve head drusen is very different from the recumbent lazy V pattern of the subretinal hyperreflective space which is seen in optic disc edema. Now coming to idiopathic intracranial hypertension and papilloedema, most clinicians would say that a good ophthalmological examination as well as a fundus photography documentation is good enough in a patient of papilloedema. So why do we need OCT in these patients? The first reason is that there can be an inter-observer agreement on grading the severity of papilloedema. Another thing that we've already discussed is that pseudopapilloedema and papilloedema may sometimes be difficult to differentiate when surface drusens are not present. The third reason is that as the optic disc edema decreases, there could be an improvement in the status of the nerve, or it could be because a concomitant loss of axons is occurring at the same time. So it is very difficult to tell whether the disc edema is reducing because of the improvement in the clinical status, or is it because the retinal ganglion cells are being lost. Another reason is that Frisson scale is a non-continuous grading scale, and a continuous grading scale based on structural features could probably be a better alternative. This is another finding that has been described by Carden et al. They have showed that due to a pressure differential between the retrobulbar optic nerve and the vitreous cavity, there is a deformation of the Brooks membrane, as we can see demarcated by the red arrow. The degree of angling towards the vitreous can help in monitoring the force of differential over time as the intracranial pressure changes, and may also help to differentiate papilloedema from other causes of pseudopapilloedema. Wong et al. Has given a grading in which they have described that a 3D segmentation approach can determine the volume and thickness of the retinal measurements, which can provide a continuous alternative to the ordinal Frisson scale grading. Another thing that comes in patients of papilloedema is that the patient of papilloedema starts losing vision. Now, one of the reasons could be that there is macular edema or macular folds that are present at the macular level, which can be an obvious clinical finding. But they could be that there is a reduction in the ganglion cell layer thickness, and that may be the reason for loss of vision in these patients. And since these patients have RNFL thickening due to edema, this is very difficult to appreciate on RNFL thickness OCT. Here comes the role of ganglion cell inner plexiform layer complex by OCT measurement, which may help in detecting early the neuronal loss in order to identify patients in need of more aggressive treatment. So we found that patients who had macular GCL IPL thinning and presentation had worse visual acuity, indicating structural neuronal loss, which was not apparent from RNFL measurements due to swelling. This is a patient in OCT picture of IIH patients with papilloedema showing normal GC-IPL thickness despite significant RNFL thickening. And this is another patient in which the RNFL is thickened due to papilloedema, but when you did a macular ganglion cell analysis, you can see that the analysis is showing cooler tones, the blue and the gray tones, indicating that macular ganglion cell thinning has started to occur. So these are the patients who are continuing to progress in spite of treatment, and these would be needing a more aggressive approach. So what we've learned from this is that you can combine the macular GC-IPL thickness with peripapillary RNFL thickness, and that would help us to get a better idea of the condition of the patient. If the RNFL thickness decreases and the macular ganglion cell thickness remains preserved, then you are having a successful treatment. But if there is a concordant reduction in the RNFL thickness and macular GC-IPL thickness, that would indicate that there is a worsening optic neuropathy. In ischemic optic neuropathy, you can have a definitive diagnosis because usually in NAION patients, the vision loss does not progress beyond 6 months. The RNFL thinning should not progress beyond 6 months. It should reach a stagnant phase. But if the diagnosis is continuing to occur, then probably your NAION is unlikely. Another thing that you can do is a longitudinal assessment of the GC-IPL layer thickness, and it can serve as an objective monitoring tool. This is a patient in which we can see that after 2 months of the acute episode, the disc pallor has developed along the superior rim, along with that a superior RNFL quadrant thinning and a GC-IPL thinning. In patients of LHON, the temporal fibers are the first affected. Then there is a subsequent range after which the other fibers start getting affected, and this may provide a therapeutic window of opportunity if we start documenting these changes. As we can see, some of these patients of LHON, we can see that these are in various stages of progression, and we can see that the nasal fibers have been spared so far. So this is the window where we can do some intervention in patients of LHON. In another patient of LHON, we can see temporal thinning. The GC-IPL thinning is showing a marked thinning, which is more striking that the thinning we have picked up on the RNFL analysis. Toxic optic neuropathy a prognosticating feature has been documented by Lee et al., where they have shown that the GC-IPL thickness and the temporal GC-IPL loss during the first 6 months was negatively associated with the amount of vision recovery at 12 months. I'll just wrap it up. So some other applications that have been documented are in traumatic optic neuropathy, where we can see the RNFL loss from 2 weeks to 4 weeks from trauma. A nasal or inverse RNFL loss has been seen in patients of vigabatrin. Optic chiasm syndrome and patients of thyroid eye disease, etc., where there is a chiasmal compression occurring or orbital decompression is needed further in the future. If we see that RNFL loss has already occurred at the time of surgery, we can say for sure that the visual recovery may not be adequate in the future. So what should be the considerations when we are assessing RNFL and GCL measurements? First thing is that it is an automated software which may be affected by the quality of OCT image. If the image is below the acceptable range, then we may have issues in our analysis. The center of fovea that is assumed by the software does not always correspond to the retinal locus of fixation. In some cases, in eyes with ocular pathology, the software incorrectly detects the boundary of RNFL and GCL. The different instruments which are available have different measurement protocols. And also there is an OCT floor effect whereby the mean PNRFL thickness do not generally reduce below 30 micron regardless of the extent of optic nerve injury, making it very difficult to detect appreciable change in severe optic atrophy cases. These are some of the advances which have come up in OCTA. A study done at our center has shown, okay. So to conclude, I would like to say that the scope of OCT in neuro-ophthalmology continues to expand. It can be a valuable aid in diagnosis, monitoring, and prognostication. However, it is a computer-generated software, so it must always be considered in addition to the clinical interpretation, as it has a potential for inaccuracies or artifacts. Thank you so much.
Thank you, Dr. Asmita. That was a very comprehensive coverage of the OCT and its value, which is significantly increasing in management of optic neuritis and other neuro-ophthalmic disorders. I will request Dr. Swati to talk about COVID and neuro-ophthalmology, which has now become one of the most interesting, important topics of discussion over the past 1.5 to 2 years. And we have seen a fair amount of patients of neuro-ophthalmic disorders in association or in patients with COVID. So sometimes we are not very sure how strongly the association is, but of course, you have to always keep in mind. Can the slides be projected? Dr. Swati, please.
Thank you, sir. And now we come to the toast of the season for last 2 years, COVID. So a lot of manifestations, including neuro-ophthalmological manifestations, have been noticed in cases of COVID. And I'll be taking through this presentation. So coronavirus, as we all know, is basically an RNA beta coronavirus and has a very high affinity for AC2 receptor, and through which it acts and gives all kind of manifestation. The other way could be an immune mediated reaction. So what started basically as a respiratory system disease has now turned out to be a multi-system disease, and ophthalmology is not spared. So there are various ophthalmological manifestation of anti-segment in posterior segment, orbital, and of course neuro-ophthalmology, which we will be talking about in this talk. So around 36% of cases of COVID will show some or the other neurological features as shown in the study by a study from Wuhan, China. And neurological features were seen in around 57% of cases in a study from Spain. So neurological disorder with the likelihood are more commonly seen in patients which have the history of in-hospital admission. So pathomechanism, there can be numerous pathomechanism. It can be a primary neurotropism. It can be an immune response due to cytokine storm. It can't be a secondary to a complication due to hypercoagulability state. Can it be a vaccine related, or it's just an association and incidental finding happening in a COVID patient? So we can never be sure of the exact pathomechanism. So there are various neuro-ophthalmological manifestations: headache, vision loss, mainly due to optic neuritis and papilloedema, disc edema, eye movement disorders presenting as cranial nerve palsy, nystagmus, myasthenia gravis, and neurological syndromes, cortical diseases presenting as CVAs and Press syndrome. So pathophysiology basically involves, as I was saying, could be a direct mechanisms of the nerve directly the virus directly invading the nerve, or it could be related to the inflammatory storm that we commonly see in COVID patients, or it may be because of the hypercoagulative rate. So each of these immune mechanisms or each of these pathogenesis have a different manifestation depending on at what phase the patient is. So coming to the individual manifestation, as optic neuritis is reported both in active as well as in recovery phase. It can be because of the increased cytokine storm or an immune mediated reaction. It is more commonly seen in patients of NMO and MOG. What I'm trying to say that patients who have COVID are showing More commonly, the presence of enema-associated antibodies or MOG-associated antibodies, generally seen 4 to 6 weeks, and is usually bilateral in presentation, may or may not recover with steroids. So this is just a case to show that this lady presented with vision loss for 5 days. She has a history of COVID 2 months back, has a history of diabetes for 10 years, and the visual acuity in right eye was very poor. There was right eye RAPD, and this was her fundus picture. You can see the disc edema was there in the left eye. So what appeared as an ischemic optic neuropathy in a first glance was on MRI was shown that both right and the left optic nerve was thickened, edematous, and had bilateral enhancement with a fast and standing suggestive of an inflammation. So what appeared as an ischemic optic neuropathy has turned out to be an inflammatory optic neuritis. So we recently have reported another case of neuroretinitis in association with COVID, where a lady presented with diminution of vision for 10 days and a history of COVID 1 month back. There was no other finding except for disc edema and a macular star. And on investigation, the only finding was raised CRP levels. We gave her steroids and she recovered over a period of time. Papillophlebitis has also been reported in literature, although there is just one case, but the possibility is always there because of the hypercoagulability. There can be a disc edema along with the venous congestion. Papilloedema has now been increasingly reported in cases of COVID patients because of its hypercoagulable state and pro-inflammatory state. Cortical venous thrombosis is commonly seen in, and therefore the MRV becomes mandatory in these cases, and in children it presents as Kawasaki disease syndrome involving multiple systems of the body. Raised inflammatory markers and altered sensorium is also seen in these patients. Posterior reversible encephalopathy syndrome is now commonly being reported in these patients, which is an altered mental state along with the visual impairment and occipital and parietal lobe edema, which has a characteristic MRI finding, and various cases have now been reported. Again, cranial nerve palsies, which can be reported as which are seen as an isolated cranial nerve palsies or part of various syndrome. They can be third nerve involvement has been reported, fourth nerve palsies, sixth nerve palsies have been reported in association with COVID-19, generally within the few days of fever and onset of cough. Even neuro-ophthalmic conditions like INO have been reported. Sixth nerve palsy can also be seen in association with raised ICT. So syndromes like Guillain-Barré syndrome and have also been reported. There have been cases where the MRI have been shown to have the direct cranial nerve inflammation suggesting of direct neurotrophic mechanism of the virus. Progressive bilateral facial palsy have also been reported, and some of these cases have shown the response to immunoglobulin. Movement disorders in form of ocular myasthenia gravis is reported in multiple cases in association with COVID, and the antibodies directed against the SARS coronavirus may also cross-react with the acetylcholine receptors, which may lead to the manifestation of myasthenia gravis kind of a picture. Again, nystagmus may be seen because of cerebellar involvement in association with ataxia and myoclonus. Then it's also other feature could be, it can also be seen in association with INO and vestibular dysfunction. Pupillae disorders, Eddy's pupil has been reported. Then anisocoria has been reported due to presence of third nerve palsy. And in encephalitis also pupillae disorders, slow responding pupil has been reported. Headache is one of the common complaints as more commonly seen in health workers. It's usually pulsatile, de novo incidence of headache, which is localized to forehead, temporoparietal and periorbital region, which may be relapsing and resistant to common analgesics. The pathophysiology of headache is either related to the increased cytokine levels or indirect activation of trigeminal nerve due to the virus. Then COVID-19 and stroke, I think, is one of the most common manifestation which we have seen in the last wave, which India had faced in last year. So there was around 7.6-fold increase in odds of stroke along with the COVID virus as compared to the influenza virus, and this kind of stroke was generally large vessel stroke. especially in young. So we have now multiple cases of such kind of patients. The most common mechanism seems to be an increased level of the inflammatory markers in these patients, and it could be post-immune mediated response as well. The COVID vaccinations are not without their complications, and multiple complications even with vaccines have been reported, like acute macular neuroretinopathies have been seen. There have been reports of Bell's palsy, reports of CSR, reports of various vascular occlusion, CRVO, CRAS, all have been reported with the vaccines. So to conclude, there is growing evidence of neuro-ophthalmic manifestation in COVID, either during the disease course or even after the disease has subsided. So, and sometimes it can actually be a presenting features of these patients. So is this association is true, or is it just a coincidental, or just two things are, co-presenting at the same time? It's still to be confirmed and needs to be ruled out. However, this differential should be kept in mind, particularly in the current setting of this pandemic. And it's important to rule out COVID with the help of RT-PCR, antibody titers, and coagulation monitor markers to completely diagnose these cases. Thank you.
Thank you, Dr. Swati, for an excellent coverage of COVID-related neuro-ophthalmological conditions. While we are loading Dr. Digvijay's talk on NAION, any questions or any comments anybody would want to make? So, the role of DMDs, disease-modifying agents. The role of DMDs in preventing long-term development of multiple sclerosis is definitely there. Unfortunately, even now, the cost related to that is fairly significant, and it's slightly under 1 lakh a month. So also, of course, although now oral medications have been developed, still subcutaneous injections are a reason why we have not so aggressively moved to use DMDs in patients suspected or possibly likely to develop MS. But again, should work in conjunction with a neurologist and plan based on the likelihood of long-term. Younger the patient presenting with a larger number of symptoms or involvement of areas like involving long tracts, lower limbs, definite evidence of optic neuritis, past history of recurrent episodes. These are cases you will strongly recommend for DMDs. First time a patient comes with optic neuritis and recovers and is good, and there are no significant changes on the MRI, maybe you would still wait for a bit and follow up such a patient while discussing with him the possibility of developing multiple sclerosis and talk about DMDs accordingly. So currently, I would say DMDs, you work with a neurologist who are very aggressive in prescribing DMDs, but you need to look at the background of the patient and the profile and the risks of developing multiple sclerosis. Yeah, Dr.
Yeah, so unfortunately, Dr. Digvijay could not be with us. He is an ex-RPC alumni and currently a private practitioner in Gurgaon, and and visits multiple centers here, and a very prominent neuro-ophthalmologist. So it's a recorded talk where he has, recorded it before sending it to me, and I'll be just moving on his slide.
You can turn on the audio.
Yeah. Audio nahi aa raha. आप अपने इसमें कर दो. Do you have the pen drive? दे दो, इसी में कर सकते हैं. In the meantime, we can take up the questions till we resolve this issue of AV.
Yeah. Absolutely. Even earlier, while you would have a coexistence of COVID with a patient presenting with a neuro-ophthalmic problem, you're still even then not sure. You would say that by temporal association there is a likelihood, but because there was no significant difference in the manifestations, although some have reported a poorer outcome in the long term, it's a little difficult. I mean, if even then and now, as you mentioned, it's very difficult. It could just be that the disease per se, and that is the recent or the more general consensus about COVID-related neurological or any symptom that we are seeing, particularly autoimmune related, is that probably COVID or the vaccines have accentuated the response of the body to a pre-existing likelihood or risk factor that could develop or occur in these patients. So maybe the association is not so much as the etiological responsibility of COVID being there, but possibly it is making a person who has a risk factor or a likelihood actually develop it, whereas if he had not developed COVID, he may probably pass on his life without a possibility of developing such a disease. So that is, and we have as of now not changed our management protocols, even if the patients have COVID in the past, except of course if you have to give steroids, you have to do that in conjunction with the physician and discuss the possible long-term effects. That's the only modification that we have as of now definitely done. But other than that, we still work on that as before. So that's not changed. But yeah, as you mentioned in the second wave and just post the second wave, we had a huge number. I think all were flooded with a lot of neuro-ophthalmic symptoms. So that was a worry that was there. But now, of course, I think subsequently to the second wave, a couple of months after the second wave, I think things have settled down and we are not anymore worried about it. So in fact, mucor was something, I mean, the way things were changing, mucor was presenting and we were like not sure what's going on. I mean, we would have seen mucor in May, maybe once in 3 or 6 months, and then we were seeing 3 or 4 in a month, and then suddenly it peaked to 20 a day. So that really shook everybody up. Same for papilloedema. I mean, again, we were not seeing so frequently, but in the last year we saw a huge plethora of cases with papilloedema. And again, we don't know. Of course, papilloedema possible likely is there because you know that hypercoagulability was a problem associated with COVID. So that was a possible likelihood. We could discuss NAION just like that. In fact, the biggest worry of NAION has been now that it has actually changed our understanding and initial management. Earlier, life was very simple. Patient above 40, most likely NAION. Younger than 40, most likely neuritis. Now, with the NMO coming in, our life is now very, very difficult. You have to actually weigh the likelihood of NAION. You have a patient who presents with unilateral sudden onset loss of vision with disc edema in the peri-50s. You may still have NMO presenting at that age. So earlier, I would have thought that, especially if he's diabetic, I would have said nothing to be done, just relax, no interventions. I'm not in favor of giving steroids and definitely not to patients of diabetes presenting with NAION. So there was no worry at all. Now, offhand, one has seen offhand 1 or 2 patients every once in a while who actually turn out to be NMO or MOG positive, particularly NMO. And that has required us to actually shift to the extreme other end because NMO requires very aggressive steroids in the initial period and obviously follow-up management. So earlier I would have really said that, older than 40, really think before you start diagnosing a patient as optic neuritis. I would still say that it would not likely to be demyelinating, but the possibility of NMO cannot be ruled out. And if there are atypical features or if the patient is typical feature of NAION would be sudden onset loss of vision. It's going to be within minutes to hours. He's going to complain of sudden onset loss. Maybe it may be initially that he may have a small area of field effect which is noticed, and by the end of the day he'll say, or the next morning he'll say it's now become severe vision loss. But the vision loss and significant vision loss has occurred within a matter of minutes. So that is a very, very important suggestion that it's ischemic in origin. And based on that, I would think more in terms of ischemia, but otherwise, whenever in doubt, I would think in terms of getting him an NMO test at least, so that if I require to give steroids, I should give. Unfortunately, the test does take a bit of time. So even for any ION versus optic neuritis, it is more for your clinical acumen, what you likely think. And because of that, yes, I would accept we have possibly gone wrong in some other cases. But yeah, I mean, steroids possibly, but standard dose oral therapy really makes no sense. If demyelinating optic neuritis is actually contraindicated because proven increased risk of developing recurrent optic neuritis, which is definitely not acceptable. And it does not do anything, any ION, it has not shown to have any significant long-term benefit. NMO, again, it's like homeopathic doses for NMO if you're giving oral steroids in the regular levels. So really, I mean, for optic nerve related disorders, either we are thinking we need to give steroids, you think of giving steroids in the required doses, or else we could even, not give steroids, because in most cases, oral steroids have not found to be. Only one case where oral presentation.
Audio is not working. I think I'll
so
just
I guess run through just a few of the slides. I
I'll
think
just
our
run
next...
through, chairperson is already here. Yeah, in continuation with your discussion, sir, I think maybe we can now try to do neuroimaging in more of NIN cases than we used to do earlier. So it may help us in giving some clue whether it's an inflammatory thing actually or ischemic. Right, so coming to the NIN, unfortunately, I don't know how much justice will I be able
Slides
to do
are
with
not
Dr.
there.
Digvijay's presentation. I'll try to do my best. So it's an update about NAIN, and we all know that it's a common cause of vision loss in the elderly population, presenting generally in 6 to 7 decade, and is caused by the occlusion of the short posterior ciliary arteries. There are certain ocular risk factors like optic nerve head drusen, like optic nerve cup, a small optic nerve head along with a small cup causing a structural crowding there. Then can be systemic association like diabetes, hypertension, hyperlipidemia, cerebrovascular diseases, and hyperhomocystinemia. It generally presents as sudden onset, painless loss of vision, monocular loss of vision noticed on awakening. So that's a classical history, the classical complaint patient will come up with, that on getting up, I realize that I have no vision in one eye. Systemic symptoms are usually absent. Around 30% of patients may have a normal or slightly reduced visual acuity. However, most of them will have moderate to severe vision loss. Visual defect will be typically in form of an inferior altitudinal defect, although superior altitudinal defect can also be seen. Then there can be central or paracentral scotomas, which are very rare. Quadrantic and arcuate defects, I would say, are more common. Dyschromatopsia is seen as with any other optic neuropathies. The kind of disc swelling we see, which can be segmental or global depending on the severity of ischemia, the disc swelling. This kind of disc swelling resolves over a period of 3 to 6 weeks, and eventually the pallor ensues. The 5-year risk of other eye involvement is seen in around 15% of cases and may present as pseudo-Foster-Kennedy syndrome. As far as treatment is concerned, there is no definitive treatment in spite of multiple treatment strategies that have been tried in these studies. So this is a case of NAN where you can see that there is a classical small disc over here with edema, which is leaking on fluorescent angiography. The other eye is also very small, crowded disc, suggestive of disc at risk. So what is new in our understanding of this particular disease? Number one, now because of the advent of OCTA, we have realized that there is definite and ischemic pathology involved, and both peripapillary as well as macular vascular densities have been shown to be decreased in cases of NAIN. And multivariate logistic regression has shown that there is a correlation between higher levels of RDWs and NAIN that may be associated in this case. So what is new in the treatment? As far as treatment is concerned, as Sir was saying that steroids are still controversial if it's a typical case of NAIN. However, we may never be sure that whether it's an NAIN and inflammatory. So whenever in a doubt, please do neuroimaging. Please rule out the atypical optic neuropathies, particularly MOC positive and NMO positive optic neuritis. And steroids may have some role in those cases, but definitely not so beneficial role in cases of ischemic optic neuropathies unless it's an arthritic ischemic optic neuropathy. So there multiple studies have been done to note the impact of the steroids on the outcome, and these studies have shown that the steroids may have some beneficial effect on the disease process. However, there are equal number of studies to show that the steroids do not offer any added advantage on the recovery of vision in cases of NAIN. Then there are adverse effect of steroids also, which are reported in these cases and therefore should be used only with caution wherever indicated. Novel treatment in form of this particular molecule QPI-1007 was an siRNA and has been tried, but however no much benefit has been observed in phase 2 studies, and therefore the entire multicentric study was discontinued. Other molecules in form of retinol ROCK inhibitors, which have the neuroprotection property, have been used in this condition, but still it's in the research stage and no clinical implications have been noted as of now. And therapeutic intervention, as this particular study has shown, meta-analysis has shown that any form of treatment, whether steroids, dopamine, erythropoietin, have not shown any kind of beneficial effect over the placebo therapy or over the observation in patients of NAIN. Now, as I presented earlier, also there are a lot of COVID related complication, and NAIN is one of them because of hypercoagulative state, hypoxia, and maybe also because of chronic proning. NAIN have also been reported after the vaccination. Thank you.
Thank you, Dr. Swati, and thank you everybody for attending the Neuro-Ophthalmology course. I guess it now
Thank
moves
you.
on to
I would
retina.
like to thank my co-speakers and particularly audience for being such a patient listener. Thank you.